In today's episode of the Dr. Greg Jones Optimization Academy, we're going to dive into one of the most underdiagnosed and underestimated threats to longevity, sleep apnea. Now, sleep apnea is not just about snoring and daytime fatigue, it's a full body disruptor, one that silently increases your risk of heart attack, stroke, diabetes, dementia, and even cancer. And the worst part, most people don't even know they have it. So joining me today is Christina Finnerty, nurse practitioner, a nationally recognized expert in integrative and functional medicine. With specialties ranging from hormone health to regenerative therapies and sleep medicine, Christina brings a unique system-based approach to optimizing recovery, brain health, and yes, even better sleep. So today we're going to unpack how untreated sleep apnea accelerates biological aging, disrupts metabolic health, and shortens lifespan. You're going to hear about the most effective treatment strategies from the dreaded CPAP to peptide therapies to diet and nutrition, and how clinicians can help patients reclaim both the quality and quantity of life. So whether you're a clinician treating complex cases or someone who just wants to feel sharper, sleep deeper, and live longer, this episode will change how you think about the power of a single breath. Let's dive right in. All right, Christina, welcome to the show.
Thank you so much. I'm so excited to be here.
Oh, thank you. And I'm happy to see you again. And so a little backstory is I gave a presentation at a Calm here. It was at late February, and I spoke on sleep. And I remember you rolling up on me. You're like, that was good. Why didn't you talk about sleep apnea? And I'm like, first of all, lady, who are you? Second of all, like, I only had 30 minutes.
I told you what an amazing job you did. I did. It was the best talk on sleep that I've heard, especially, yes.
Oh,
so
my
it was
God.
great.
Okay, I appreciate that. I didn't even leave that part out. It wasn't all like throwing tomatoes at me when I got on stage. But the crazy part is you looked at me, he was like, in so many words, like, I think you got sleep apnea. I'm like, wait, what are you talking about? And you're like, look at your neck, look at your mouth. Yeah, you should get tested. So, in a much nicer way, she said that, right?
Nice.
Turns out, then I was like, so little crazy lady from Idaho, I ain't got time for that. And then I was like, you know what? Let's do it. Finally. And then it kind of turns out I had some mild, slightly moderate sleep apnea. And I'm like, she's good.
Yeah.
She's good. And I was like, all right, let's get her on the show. Let's talk sleep apnea, right? So, but before we get into it, I want to know about your journey, right? Because you're a nurse practitioner. So you have to start off as a nurse,
Yes.
right? You do have to start as a nurse,
Yes.
right? Yep. And then you went back to school, got educated, and now you're doing a lot of cool things up there in Idaho. So tell us your story.
Yeah. So I graduated in 1999, which seems like a really long time ago. With my nursing degree, and then 2003 with my nurse practitioner. So I've had an amazing opportunity to do a lot of different things within medicine. Started out in anti-aging, what we now call longevity medicine, went into women's health, did some urgent care. I worked at a sleep specialty center for 10 and a half years, which is where I really gained my love for sleep medicine, for really understanding that it's just the foundation of everything. Like if you're not sleeping, if you're not breathing, there's just some problems in life. And then that doctor passed away and I ended up going into practice with some other providers. I own my own practice with 5 other providers and then really started doing a little aesthetics and then branched out my whole longevity medicine. So I'm fortunate enough to have primary care medicine, but also have longevity. We do IVs, we do EBU, we do the whole gamut. And so over the past 23, 24 years of being a provider, I really have loved the value of knowing, all of that foundational sleep medicine, because I really do describe it as the foundation to everything. And so that's a little bit about my journey.
All right. So what's the name of your clinic?
It is Ridgeline Aesthetics, or Ridgeline Longevity and Aesthetics. We just recently branched our name out instead of Ridgeline Medical. So Ridgeline Longevity and Aesthetics.
Okay. And is that in Ridgeline, Idaho?
It is in Idaho Falls, Idaho. We happen to live by a ridgeline, so I suppose that's why we named ourselves Ridgeline. Mountains.
We were talking before that when I was in the Navy, I was stationed in Idaho Falls for 6 months. This was, I'm about to date myself, about to carbon date myself. This was in 1994. Yeah, 1994, January 94 to July of 1994. And my story of this is I left in July 2004. I don't know if it was like a weather anomaly, but it was literally 38 degrees. And I think it was about to snow.
Yes.
And this is July, and I was like, man, I couldn't get out of there fast enough, man. I was
Absolutely.
like, how fast can I get out of this city
We're gonna
and
get
out of
you
this
back,
cold,
though.
right? But I had to,
You're about to come back
oh my
30 years
goodness.
later. We've 30 plus years.
Yeah, never know. Were you there in 94?
Yeah. Yeah.
Oh my God. You know what? I might have saw you at the grocery store or
Could
something.
have seen you walking
Uh,
down the road. I wouldn't have even known it. Although, yeah.
I wouldn't have been walking in wintertime Idaho Falls. I'd tell you that. So,
I meant in the
bundled
store,
up
not
like the
to the store.
abominable snowman is all you would have saw.
It is
You know, it's
cold.
kind of even inside. I wasn't taking that stuff off,
Yeah.
so probably would have like you just saw eyes in the scar. So I want to get into this here because I think this is such a fascinating topic here, and I want to start with the basics. What exactly is sleep apnea, and why is it so much more dangerous than most people think?
Yeah. So sleep apnea is basically when your tongue falls into the back of the airway. Generally, people that have OSA already have a crowded airway to begin with, maybe narrow jaw, small airway, large tongue. And that's why I tend to be able to tell just by listening to people and having them talk. But essentially, it is the tongue falling back into the back of the airway, either totally or partially occluding the airway, dropping the oxygen level. So it's not just snoring. A lot of people say, well, um, uh, we can't tell by just listening to someone if they have OSA. Snoring could just be a deviated septum, nasal polyps, allergies. And that's why, as we're going to get into this, sleep studies, but it's a significant drop in oxygen, at least 4 points from where you are when you're awake, over a 10-second period of time and over 5 times an hour. So there's very specific criteria. It's not just not breathing for a few seconds or loud snoring. But that is essentially what OSA is. And the reason that it's a problem is, as you know, if you drop your oxygen, you're stressing your heart out, you're putting yourself into sympathetic as opposed to parasympathetic, where we're supposed to be resting and digesting. Your brain isn't getting into the deep stages of sleep. So the bottom line is you have a higher risk of heart attack, stroke, high blood pressure, diabetes, pain, depression, cancer, Alzheimer's, dementia, just to name a couple things.
And we're going to dive into those individually as well because I definitely want to have the listeners and even for myself get a better understanding of the longevity impacts. And if I'm hearing you right, it's like you're basically almost like your brain's like drowning itself.
A little suffocating.
Suffocating, right? Suffocating, all that good stuff here. But here's the thing: most people don't know they're having episodes, and that part kind of, I want to say is like, wait a minute here. So if you're thinking like you kind of have that suffocation, you stop breathing, and a lot of times, because even with my own score, it said, hey, you're having these events, 15, 20 times an hour, and I'm like, I don't wake up 15 to 20 times an hour.
Right.
So do the studies show why, or some of the physiology of why the person doesn't fully wake up when they have most of their episodes?
Yeah, and sometimes we do fully wake up, but you just don't remember it. So when we go through sleep is a very definitive going through different stages. So we go from being awake into stage 1 sleep, stage 2 sleep, stage 3 sleep, stage 1 sleep, REM sleep. And so when we have obstructive sleep apnea, we may be hanging out in stage 2 sleep and the airway starts to occlude, the oxygen drops, and the brain says, hey, wake up. And it might just be into stage 1 sleep. So you're not fully awake. So you don't know that you're waking up. But over time and throughout the night, that is inhibiting your brain's ability to get into that slow wave sleep. And that's the only stage of sleep we heal, repair, and regenerate in. And so if you're constantly it's called fragmented sleep. And we'll see that on the sleep study when you have EEG leads on your head, is we will see you be woken up all night long, not to the point where you're fully awake and you know it, but out of deep slow wave sleep. And that is why it's detrimental long term, is because it's inhibiting that slow wave sleep, because your brain is really good at just keeping you alive. So it's fragmented.
Okay. It's good to know. It's good to know because I think that's why some people, again, if you're the person who doesn't fully wake up, it's hard to, if you're not sleeping next to someone who's telling you that you're having episodes, and we'll get into some of the signs and symptoms, it would not cross your mind. Because again, if you're not fully waking up, it's like, oh, I slept throughout the night, especially if you're not tracking it, you won't know, and that's wild to know that you could be having all those episodes and not even know it without someone saying, "Hey, you're scaring me. You're gasping for air."
Yeah, and that's a lot of times
So
where
that's
I'll ask people, do you have a hard time sleeping? And they're like, "No, I sleep fine," but yet they wake up exhausted and or they wake up fine, but they're tired all
mm,
day, or maybe it's just that their hormones are off or they're gaining weight, and we're going to get into all that. But most
yeah,
people
for
do
sure.
not know that they have sleep apnea unless they've got a spouse or someone that's in bed with them saying, "Wake up, roll over, like you're driving me crazy."
Okay, so let's get into some of the longevity stuff because just from, reading up on the topic, the understanding is that sleep apnea can accelerate aging. And I saw the main three areas, and there are more, we'll go into it. But the number one that I saw was cardiovascular aging and cardiovascular health. So, how does sleep apnea affect heart health?
So when we are having the obstructive events at night, that, as I said, means that your oxygen level is dropping, generally below 90% and for over a certain period of time. That immediately tells the heart your heart's job is to pump blood. Its main job is to pump blood and get oxygen around to the rest of the body. And so when you have those obstructive events, the oxygen level drops, the heart rate will increase. The blood pressure will increase. That's how the heart rate increases. And year after year after year, night after night after night, that is putting significant stress on the heart. It's also throwing you more into that sympathetic phase where you're putting out cortisol when you're supposed to be resting and repairing. It's not allowing the deep sleep. So it's increasing the heart rate, it's increasing the your blood pressure, and over time it's actually causing left ventricular enlargement of that left side of the heart because of not getting enough oxygen. So it can lead to things like congestive heart failure, even atrial fibrillation. A lot of the heart arrhythmias occur secondary to obstructive sleep apnea rather than prior to it. So it's just making your heart work harder.
Gotcha, gotcha. So, it's almost like it sounds like your physical analogy. Love my analogies there, Christina. Is that it's like a car being in park and you're just kind of revving the engine all night.
Mhm.
Just kind of burning fuel, not going anywhere, just kind of like the engine's going, but not going anywhere. And that can damage some of the parts of the engine. That's some of that endothelial dysfunction. So I don't know if that's a good one. When you said that's what I was kind of thinking
I
about. I
like
was like,
it.
it's like you're sitting in park,
Yeah.
just revving up. So the next one is cognitive function and neurocognitive health. What's the connection with sleep apnea and brain health?
Yeah, so that one is huge. And again, we need oxygen. Our bodies need over 90% oxygen on a consistent basis. And when it drops, you're starving your brain of oxygen. So, number one, your brain isn't getting oxygen, the brain cells start to die. But number two, again, if you're not getting into that deep, slow wave restorative sleep, then your brain isn't detoxing. The only time your brain detoxes and your body detoxes really is in stage 3 sleep. And so, any disruption in stage 3 sleep significantly increases the risk of things like Alzheimer's and dementia. There is a 100% clear cut correlation with dementia and obstructive sleep apnea. And it's because of that interference with deep sleep and the interference of not having enough oxygen to the brain and being in that sympathetic state, all of the excess cortisol, the stress hormones. It just is this whole cascade of everything just gets off. Your hormones are off balance. You produce, you don't regulate your insulin well, your blood sugars increase, and then you start getting disease, which also increases the risk of Alzheimer's. We have a higher percentage of type 2 diabetes and insulin resistance, which we know is directly related to Alzheimer's.
Okay, gotcha. And then you kind of the next one I was going to get into is the metabolic disruption that it causes, but I think you basically answered that. So cortisol dysregulation, insulin resistance, and that's weight gain and difficulty losing weight. And I think that's where the struggle comes in for those people who don't have the partner who's like, hey, like you say, your sleep disruption is disrupting my sleep, kind of thing, right? Where you have that. It's just that the things you said look like other things. Everything you said, that looks like mitochondrial dysfunction. That looks like chronic inflammation. That looks like metabolic inflammation or metaflammation. It looks like that, and I think that's where a lot of times it gets missed because again, if someone came in with this thing that came in with the symptoms you're talking about, is like, okay, I need to run some labs on you. We need to change your diet, right? We need to change your sleep kind of architecture, sleep hygiene. Let's go with that, and sleep apnea would not pop up. right? Because again, it looks like other things. It's kind of like when it comes to we're doing hormone work, it's like, well, is it your thyroid or your testosterone? Because they look so similar, you know? And so, but what gets it, this is where we're, kind of segueing you here, is what are, besides the gasping for air, what are some other signs and symptoms of sleep apnea that most people and most practitioners miss?
Yeah. So, insomnia is a big one. Difficulty getting to sleep, difficulty staying asleep. So, most people will just be put on a sleep aid or maybe some peptides for sleep, maybe some supplements. So, sleep is a big one. Anxiety and depression is another one. Um, and the just waking up with headaches, that's a big one. Irregular heart rate in the middle of the night, waking up and thinking they're having panic attacks or even panic attacks during the day. Um, and then really everything that people come to us to discuss. I can't lose weight. My hormones are off balance. I'm losing my hair. My thyroid's off. I've been diagnosed with an autoimmune disease. Like I literally, this is why I was so excited to be able to meet you at the conference and hear your talk on sleep and then really come up to you and say like, hey, how much do you order sleep studies? Because it really is something that doctors and practitioners are not taught in school. And so I'm just grateful that I fell into the path of really having it be the foundation of what I think of first. But I really want the community, whether it be, patients that are listening and or providers that are listening to know, always think about sleep. And if you're having a hard time getting to sleep, if you're having a hard time sleeping, or staying asleep, if you're waking up unrested, if you're tired during the day, and then all of those other things that we just talked about, always ask about sleep.
100%, 100%. And I think for me, now that I've kind of been more educated since meeting you and getting more into it, I think one of the things that is a flag for me, these are my fit but fatigued people. These are the, hey, everything is good. You're working out, you're eating well, your hormones are good. Everything should be working well, but you're still having that fatigue. You're like, wait a minute. It's like, hey, I'm there. I'm over. Like, I got everything, but it's like I'm struggling a little bit. Almost like if it's a cell phone that's you charge it overnight, it's 100%, but then the battery dies by noon, and you're just like, wait, I was like that shouldn't happen with a good night's sleep, right? And I think the big one is just like it. Everything should be working well, but for some reason you're still kind of tired, or you feel like you're not getting enough sleep. And I think that could be a big flag for it. It's like, okay, let's check for that. And then especially, if they wake up with the dry mouth thing, especially for guys that are snoring. But which leads me to our next question here is, do these symptoms differ between men and women?
Um, Really, I find that men are pretty good at justifying that it's not obstructive sleep apnea. It's something else. I work hard. I'm busy. I'm it's always something else. In women, and so it's usually what brings men into the office most often is somebody else saying, you better go get your snoring fixed, or I'm seriously going to put a pillow over your head and end it. Because it's so hard to listen to someone snore all night. So it's usually a spouse that is saying, to a male, you need to go in and get this tested because I can't do this anymore, or I'm going to have to start sleeping in another room. To females that I see come into the office, they are generally mislabeled as anxiety, depression, or it's just because you're overweight. So to females, a lot of the time they're coming in talking about anxiety and depression and or insomnia. Insomnia is a big one. Lots of people go to their provider and say, I can't sleep. So the first thing that the medical provider thinks of is, here's your herbs, work on your sleep schedule, and or worst case scenario, not necessarily in the functional medicine world, but is they're just put on drugs to knock them out. And there are very few medications that actually induce deep, slow wave sleep. Most of the medications are just to make you forget and or really to drug you to sleep. And you can hit someone over the head with a baseball bat, you can give them a fifth of whiskey, you can knock them out with medications, and it does not mean they're going to get deep, slow wave sleep. So usually it's just something that they come into the office for something else. And unless we really are thinking about asking, do you snore? And then asking them real quick, like, open up and look in their airway. Because if all you see is the base of their tongue and the roof of their mouth, That's a crowded airway. And not everyone with obstructive sleep apnea, or not everyone that has a crowded airway has obstructive sleep apnea, but everybody with obstructive sleep apnea has a crowded airway. So it's some simple little things that you can ask and evaluate when they're talking. All you can see is their tongue. Start to think about those questions to ask them, like, hey, do you by any chance snore? Or even as little as a puff. So I always ask spouses, like, go home and ask your spouse if you at night, because just a is a hypopnea. That's a partial obstruction. It's your own body trying to positively, push some air out, positive airway pressure. So even puffing, light snoring, it doesn't have to be that you're bringing down the house, or that you're not breathing for long periods of time.
Right. How how many people do you think, and there may be some studies out there that can kind of verify that. What's the percentage of people out there that have undiagnosed sleep apnea?
Okay, so this is crazy, but so 25 to 30% of the population actually has OSA, and 80% of it is undiagnosed. It does increase as we age, because as we age, we lose the elasticity within our airway due to the declining hormones. So just like we get flabby arms and flabby legs, we get a flabby airway. So we have a higher risk of obstructive sleep apnea with each decade of life that we live. So 60, 70, 80-year-olds have a higher risk of obstructive sleep apnea than a 20, 30, 40-year-old. It is very common during andropause and perimenopause, menopause, because we're losing our hormones. And so even just that loss of estrogen, progesterone, testosterone, and elasticity within the airway increases our risk. But 80% of people are still undiagnosed. As a lot of people, 80% of the 25 to 30%.
Perhaps. Which is still a lot of people. That means if I got like, you know, shit, man, 100 people in a room, we're talking 25, 30 y'all got sleep apnea. And out of that, only 7 to 80 y'all know it. I don't know if that matters.
How long did you, it's like, how long did you go with it? Just saying, like, I'm optimizing all these things. Like, it's not sleep apnea. I just snore. Like, it's not.
Yeah, it's a long time. So for me, when I was in the Navy, I pretty sure I had it, but I mean, I was heavier, I was drinking a lot more. And so my assumption was that this is a weight and an alcohol thing. And so I just never retested. I was like, oh, okay, lose some weight, stop drinking. All right, we're good, you know? And it turns out not so much. Not so much, right? But here's a question. People that are heavy snorers, are they more likely to have sleep apnea?
They are, just because most of that snoring is the tongue falling into the back of the airway, causing that vibration in the back of the airway. Snoring can definitely be a deviated septum, nasal polyps, allergies, but that's why we have to do a sleep study, because we don't know just by listening to you whether it is obstructive sleep apnea. And people always tell me, like, well, I'm not going to do a sleep study because it's going to come back. Everybody that does a sleep study has sleep apnea, especially if you're sent to a sleep specialty center and they think that we just want to diagnose everybody with sleep apnea. I get negative sleep studies all the time. And so you can't tell by looking at someone. I'll have 350-pound men with huge thick necks and think 100% you have obstructive sleep apnea. And 99% of the time they do. But I have done sleep studies on really large people with thick necks and they don't have it. Whereas I can do a sleep study on a totally fit, thin female, no thick neck, and they have severe obstructive sleep apnea. So that's why you can't just look at someone and assume that it's a weight issue. It is also an airway issue. So don't just assume that it's only overweight people, or definitely people that drink alcohol have a much higher risk of obstructive sleep apnea, because the alcohol lowers our breathing threshold. And so you are more prone if you are drinking alcohol.
Okay. So we went through two pretty major things with the cardiovascular and neurocognitive or neurological impacts of sleep apnea. And before we get into the testing and the other side of this, is that damage reversible?
So the wonderful thing is that neurologically, our brains are neuroplastic. It's one of the really cool parts about modern science that we've learned in, really, I think, just the last 15, 20 years, is that our brains can regenerate. So the neuroplasticity with our brain is, you can regenerate that. The heart Yes, you can, you can lower the blood pressure, you can stop the damage, but once that left ventricular um, heart wall is thickened, you can't unthicken that. And so some of it is reversible, some of it is not reversible.
Yeah. And it's like a roof, if that roof had a leak, you wanna stop it early. I feel like the earlier you stop it, the earlier you address it and find it,
Yep.
the better chance you have to saving the house, or at least you might get some water damage, but you can still save the house, right? And so finding the leak, see what I and I'm about to segue you into testing. You see what I did there? See,
Perfect.
I just kinda ease you into it here. So so how do you approach diagnostics? Are you more of a home study person? Are you more, hey, go to the lab and do it? What's your kind of preference, or do you take it case by case?
I will say that when I worked in the sleep lab, it was much easier to order an in-lab sleep study, a polysomnography. Um, but what I learned through 10 and a half, now more like 15 years of doing sleep medicine is I don't need an in-lab sleep study to know how to help you with your obstructive sleep apnea. And I am much more likely to get somebody to do a home sleep study than I am to tell them they need to go to the sleep lab, be hooked up to a bunch of wires, sleep in a strange place. And so the only time I will do an in-lab polysomnography is if I am really wanting to know what is going on with stages of sleep, because a home sleep study, generally there are newer home sleep studies that'll give us a good idea of stages of sleep. They're not as accurate as in lab. But there is one called the Sleepify that goes on your wrist and on your finger. And that one will give us a brief idea of the different stages of sleep. But it is so much easier to say, listen, we're going to do a home sleep study. It's not a big deal. You get to do it in the comfort of your own home. And it could be as little as this little tiny, there's one called the Night Owl, and it just goes right on the tip of your finger. It is so simple. Is that the one you did? Did you do Night Owl or Sleepify?
Um, I know it's through Virtuox. I feel like it was Sleepify. It was
Sleepify,
like
it was
the
at a
ring was a
wrist.
little bit bigger. It was a ring, but it was a little bigger. It went around my thumb. It was kind of a
Oh, so you did an even different one. Okay. So yeah, there is a ring that can go on your thumb. There's a wristwatch and a oximeter. There's the little night owl. Either way, it's a $250 cash pay test. It is so inexpensive. It is so easy. I have people do it for 2 nights just because invariably one of those nights you're not going to get good sleep, or I just like 2 nights to compare the data, and it will tell us stages of sleep if it is the Sleepify. But mainly, all I need to know is how many breathing events are you having per hour and what is your oxygen level dropping to? And it will give us graphics where it will actually show here's how many breathing events. And they don't all quantify whether it's obstructive sleep apnea, central sleep apnea, or a partial, what's called a hypopnea. We can get into that, but they'll show you your oxygen footprint and your heart rate, and it's really cool to be able to see. Here's your breathing event, here's your oxygen desaturation, and here's your elevation in heart rate. Because for the most part, you can clearly see that correlation. So it really helps me to tell people this is what's happening to your body at night, and the amount of times that oxygen drops, especially if somebody is having 20, 30, 40, 50, 60. I mean, I've seen upwards of 300 breathing events an hour in people that didn't even know they had sleep apnea. Um, so I will say 99% of the time now that I own my own practice and I'm not in a sleep lab, I'm ordering home sleep studies.
okay. So this is a big question I should have asked you earlier, and it kind of leads me into my next question on the testing. What's the difference between central and obstructive sleep apnea?
Yeah. So central sleep apnea is when the brain doesn't get the right signal to breathe. So we have something called chemoreceptors. We have them on our heart and we have them in our brain. And they are very sensitive in that they measure carbon dioxide and oxygen. So when your carbon dioxide gets too high, it tells because you're not breathing. So when oxygen drops and carbon dioxide gets too high, the chemoreceptor is supposed to tell us to take a breath. In central sleep apnea, that chemoreceptor is not sensitive enough. And so it allows you to go periods of time over 10 seconds at a time where you're not breathing. So that's central sleep apnea. That can be from being at high elevations, or it can just be that is just an inherent thing that either developed or that you were born with. And obstructive sleep apnea, again, is the tongue falling back into the back of the airway, the oxygen dropping by more than 4 points from baseline over that 10-second period of time, and over 5 times an hour. And so then there's mild, there's moderate, there's severe. So we're looking, when we do the home sleep study, we're looking at how many breathing events do you have every hour? Is it less than 5? Great. That hasn't been determined to be detrimental enough to cause long-term damage to the heart, the brain, the body. 5 to 15 breathing events an hour is mild, 15 to 30 is moderate, and then above 30 is severe. And so that's how we quantify that mild, moderate, and severe obstructive sleep apnea. And then that determines too, treatment, which I'm sure we're going to get into.
No, we're going to stop right there and leave everybody hanging. I'm done with this. I'm done.
Kind of like the longevity conference when we.
It's like, all right, I'm out. You only had 30 minutes. You're done. You just got to
stay tuned for the next one.
But stay tuned when we talk about more how to treat it. But hey everyone, quick break to let you know this episode is sponsored by Tides Wellness, a company I co-founded and I also serve as medical director for. So as a naturopathic doctor, I spent years prescribing peptides in my clinic, and I helped formulate every product in the Tides line to make it high quality, effective, and more accessible. No needles, just science-backed ingredients that work. I personally take our products every day. I start my mornings with our Rebuild drink powder, and I usually take a second serving after the gym to help with muscle recovery and electrolyte replenishment. Now, when I want to unwind, I reach for our de-stress gummies. They help me relax while staying clear and focused any time of the day. And last but not least, to keep gut inflammation in check, our Revive gummies are my go-to. I use them consistently, and I recommend them to my patients all the time. So if you're curious to try them, you can get a 15% discount off your first order at yourtides.com with the code Dr. Jones. That's DRJONES. Again, you can get a 15% discount off your first order at yourtides.com with the code Dr. Jones, DRJONES. So Tides is about making cutting edge wellness simple, effective, and part of your everyday routine with the power of peptides. In all seriousness, the question I want to ask you is that can a home sleep study, home sleep apnea testing, HSAT, whatever term, I was looking at different terms for it, let me ask it a different way. Can a home sleep study accurately diagnose the central sleep apneas?
Some of them can, but therein lies the why sleep medicine is a specialty and why it can get complicated, because we can put somebody on CPAP, and even that CPAP machine, which we'll get into, that can cause central sleep apnea, which is why it's really good to be able to look at all that data and know if that's happening. But so most of the home sleep studies are not sensitive enough to diagnose that. So if I've got somebody that is not doing well, that we think should be doing well, then it could be central sleep apneas, which just made me think about something that we should go further into.
Okay. We will. We got time. We got time. So now let's, we're walking through this little case here, this little process timeline. So someone comes to your office, they have these sleep symptoms, they got other symptoms that make you suspect sleep apnea. It's like, you know what, you really need to get tested. You get them set up with the Night Owl or Sleepify. They do it. It's like, holy shit, you got 50 an hour. You got sleep apnea. Congratulations. I'm not gonna say congratulations, you know what I'm saying? But at least we have a reason of knowing what's going on, right? So we know that's going on. So now we're at the point about what to do about it.
Yeah.
And so let's talk about options for treatment, looking at the pros and cons of them, and then what your approach is to treatment and knowing if the treatment is working. So obviously we're going to break that into stages. Let's start with, what are the alternatives when that person is diagnosed with sleep apnea?
Okay. So I will go through that sleep study with them in detail. And I tell them before I even do the sleep study, no matter what we find, it's going to be good information. You either don't have it or we'll go into what to do about it and can literally save your life, because we could prevent you from having a stroke or a heart attack. So treatment options. My favorite and the gold standard, and the one that everybody is afraid to hear about and doesn't want any information on because they swear to God they're not going to do it, is CPAP. And the reason that I love CPAP is CPAP stands for continuous positive airway pressure, or more so what it is now is APAP, auto PAP. It is a range of pressures that is, you wear a mask either just under the nose or under the nose and around the mouth or over the nose and mouth. And It is hooked to a little tiny device that delivers positive airway pressure. So when you have an obstruction of the airway, you go to take a breath, you're negatively pulling air. The CPAP will sense that, and its job is to deliver a positive airway pressure, splint the back of the airway open, and then overcome that obstruction. So CPAP isn't breathing for you, it is breathing with you and just splinting the back of the airway open. The reason that I like it best is it is the gold standard. It is 99% effective, and we can document, or we can track how well it's actually working, because CPAP is what's called downloadable. So we can go in and we can look at, on a night-to-night basis, how many breathing events are you having? How is that machine classifying those events? The machines are pretty sensitive, and they can give us a good idea of if somebody's having centrals. So that's why it's so important to look at that data and determine if somebody's not doing well, why. But so CPAP, gold standard, we know it works. And if it doesn't work, there's other levels. There's APAP, there's BiPAP, there's even auto titrating servoventilators. Again, why sleep medicine is a specialty. But what if someone tries CPAP and they're like, listen, I gave it a good effort. I tried it. I hate it. I can't do it. I don't want to do it. If you have mild to moderate obstructive sleep apnea, you are a candidate for an oral appliance or even surgical options. And I'll tell people this in the beginning. So surgical options, you go see an ear, nose, and throat specialist, and they discuss something called a UP3 or a uvula palatopharyngoplasty. Big words, but all it means is they're going to roto-rooter your airway. They're going to cut out your tonsils and adenoids if they're still there. They're going to remove the uvula, because a lot of times people have a really large uvula and that's hanging down in the back of the throat, contributing to the back of the crowded airway. And that's around 30% effective. It's a very painful procedure. Nobody that has it done says it's a good time, but it's there for people that are like, I don't want to do anything else. I just want to have surgery. And then there's oral appliances. So for mild to moderate, there are dentists that specialize in mandibular advancement devices. Those are devices where they take a mold of your teeth, it clicks on tightly to your top and bottom teeth, has either a little adjustment bar on the side, you have a little key and you adjust it forward, but it's basically pulling your mandible forward, mandibular advancement device, so that you have more room in the back of your airway, so that your tongue falls forward instead of back. And those are around 50 to 60% effective. They can move your teeth. They can cause a little bit of TMJ. So if somebody already has TMJ, it's not a great issue. You have to kind of reposition your jaw in the morning. But those are the main treatments. They do say that for severe obstructive sleep apnea, really CPAP is going to be the best treatment, because if you're only going to reduce your apnea events by 50% and you have a score of 50 to begin with, you still have moderate obstructive sleep apnea. And so that's why I really try and gear people that have severe obstructive sleep apnea towards doing CPAP therapy. And if they absolutely can't tolerate it, then we say, okay, well, I'll try some other things. I do have some patients that come to me and they're like, well, I couldn't tolerate it, so my provider just put me on oxygen. And I'm like, oxygen's not going to splint your airway open. It could treat central apneas. Interestingly enough, sometimes oxygen alone will treat a central apnea. And so will CPAP around 50% of the time. But oxygen alone isn't going to splint your airway open. And if your airway is closed, then that oxygen can't get anywhere. So those are the big ones. There is one more treatment, and it's called Inspire. And I want to say something about it because everybody asks me about it. They come in and they're like, well, I just want that surgical thing where they just, put the little implant in. And that is a growing thing. It's around 10 years, but they put a little battery pacemaker under the skin. It has a lead that goes to the hypoglossal nerve, and it will, when you have an obstructive, it doesn't work for central, but when you have an obstructive apnea, it will pull that tongue forward and treat the mild to moderate obstructive sleep apnea. It's really not effective for severe, but that is an option that people ask me about.
But it's so surgical, though, right? It's minor at the end.
Yeah.
Yeah,
And
yeah. Probably gonna pass on that.
you see the battery, you see the lead, and some people do great with it.
Oh man, that's rough. I feel like the roto-rooter, we're gonna call it that, 30% effective, man. That's a lot of pain and procedure for one third of the people to be successful with it. Probably want a hard pass on that personally, but I guess to each their own. Now, for those who, and there's some people just again, because I've been more getting more into it and I've been reading a lot more about it because I'm fascinated by this now. Is there some people who are saying that they get the apnea episodes when they're on their back, but when they're on their side or their stomach, not so much. And so the question is that, especially for, it's probably gonna be more for the mild people. Is that an option, just positional therapy? Like, hey, let me sleep on my side, take it from there. Have you seen that be effective for anyone?
Yeah, so the big reason that people with obstructive sleep apnea always get the like big nudge by the spouse, like roll over, is because when we're on our back, it makes perfect sense that that tongue is going to fall back into the back of the airway much more easily. And so when our airway starts to relax just because we're falling asleep, we are much more prone to have obstructive sleep apnea on our back. The issue is it is natural to rotate and to sleep on our sides and on our back and even on the front. So keeping someone off their back is fairly difficult. There are wedge pillows. The doctor that I used to work with would tell people to sew tennis balls in the back of a t-shirt so they would stay off their back. And that really is for very mild. So you could sleep on a wedge pillow. You could do mouth tape. You could try and stay off your back. And that could, in essence, treat a mild, we're saying maybe like 5, 6, 7, 8, 9, maybe 10 breathing events per hour. And so, yes, it is true that we have more obstructive sleep apnea on our back. So if you could try and stay off your back, it's just not super reasonable though.
Yeah, and you can't guarantee it, like you said, because eventually you may roll over and then you're back to square one. Now, you mentioned mouth tape. That's more for snoring reduction, right?
Interestingly enough, for very mild obstructive sleep apnea, the mouth tape can work because it's keeping your lips shut. And what most people with obstructive sleep apnea do is, they're laying down and that they're opening up their airway to breathe, and that jaw is falling back. So the theory behind the mouth tape is that for people with mild obstructive sleep apnea, it'll keep that jaw more engaged because the mouth isn't falling open and then back. So it is potentially an option. I would do a sleep study with the mouth tape on, even breathe right strips. I'll tell people, get the breathe right strips, get the mouth tape if you absolutely don't want to do anything else about it. But then have a sleep study, because don't trick yourself into thinking that it's working and then find out 20 years later that you've been having TIAs, or you have an enlarged heart, or, you're hypertensive and you're going to have a heart attack, or you do have a heart attack.
Oh, that's one of those things. I was literally going to ask you about the nasal strips next. What you're saying is I'm probing here for alternatives. You see what I'm doing here? I'm like, what about the side? What about the mouth tape? What about the nasal strip? This is stages of grief I'm in right now. I'm just like, can I buy a giant wedge pillow? I don't know, man. Got to figure something out. So
Yeah.
negotiating with you here. I'm heavily in negotiation mode right now.
Mhm.
Okay, so now let's say the person is like, hey, you got me. I'm gonna do the CPAP here. How long does it normally take for that person to adapt to it and start seeing improvements? And I know everyone's different, but in most cases.
Everybody is different. I do find that when people have really severe obstructive sleep apnea, they take to it much quicker because they've been struggling for so long and their body is just elated to be able to breathe. For mild to moderate, it does take a little bit longer. It might take a couple weeks, it might take a couple months, but the really important thing is to make sure that you're seeing a sleep provider that is seeing you back within 2 to 6 weeks. How are you doing? And working with you, but also really looking at that download to see if you're feeling worse instead of better. Something else is going on. There's either periodic limb movements and that you don't know are happening. So those are little tiny movements within the legs due to the drop in oxygen that's occurring, and those are creating the interruption in the quality of sleep. So your brain can't get used to the CPAP, or you're actually having those central apneas that either are not being treated by the CPAP, because CPAP will only treat central apnea 50% of the time, and or you're having treatment emergent central sleep apnea, where you're actually having central sleep apnea secondary to the CPAP trying to do its job. So CPAP does take a little while to get used to. Some people take to it right away. Other people, it's months. But by, by 8 weeks in, if you're not feeling better, something else is wrong. Sometimes I have to add in medications to help the overall anxiety over putting the CPAP on. Sometimes I add in something called clonidine. So clonidine is a prescription, but it does help with restless legs. It helps with anxiety, and it helps with the overall just being able to get to sleep. And it can improve deep, slow wave sleep so that your body can then adjust and get used to the CPAP. And then we don't need the clonidine or, the other interventions as much. But don't give up. Don't give up.
Yeah, y'all don't give up, y'all. You heard what she said. It's like I'm trying to coach myself. Y'all heard her. She ain't talking to me. Talking to y'all. Well, I'm not giving up. All right. So your clinic and yourself into functional medicine. Super applaud you for that because again, looking at medicine, I consider that the future, the present and the future of medicine.
Yeah.
The integrative functional approach. So are there any integrative or functional medicine tools that you like to use with the, sleep support and the CPAP for your patients that have been diagnosed with sleep apnea?
Yeah. So it's really important to, again, always take that holistic approach and really look at the whole system. Are hormones off, and can optimizing hormones help? I actually just listened to a podcast the other day that was talking about the benefits of progesterone and obstructive sleep apnea. And I was like, wait a minute, what? And it's because if we can improve the elasticity of the airway with our estrogen and progesterone, even in men, which I have never put a man on progesterone, but it stands to reason that progesterone improves overall quality of sleep. Men make progesterone, they just don't need as much as females, and it can improve the elasticity within our muscles. And then that being said, talking about testosterone, which we can get into, but the tricky thing with testosterone is, could that also make the obstructive sleep apnea worse? Because testosterone does actually cause obstructive sleep apnea. But other things, so balancing hormones, obviously helping with weight. Every single person that we see, we want them to be at an ideal weight, not because of how we look in our clothes, but because of longevity. We know that when we're at an ideal weight, we have less inflammation, we have lower insulin levels, we have lower blood sugars, everything just improves for the most part when we can focus on eating clean and being at a healthy weight, having muscles. And so I will always look at all of those things. And sometimes people just need help with, getting their brain to sleep, even if they are trying to treat the obstructive sleep apnea, because part of the stress over having CPAP on their face is that then they develop insomnia and then they just learn to hate the CPAP. So I will use things like L-theanine to relax the brain and decrease the cortisol levels at night. I love magnesium glycinate. It is one of my favorite go-tos at night as it is calming, it's relaxing, and most all Americans are deficient in magnesium. There's things like a 0.3 of a melatonin. I don't love melatonin to get people to sleep per se, but really to set that circadian rhythm. We know that there's anti-cancer properties to it, but we only need 0.3 of melatonin. And the problem with melatonin and sleep is that people are taking a lot, and it usually just ends up causing grogginess and sedation. And it's not meant to get you to sleep. It's really to set that circadian rhythm to get you to sleep. So about an hour or two before bed, we can utilize things like melatonin. In doing my research, was looking at things like CJC and ipamorelin. That can actually improve sleep by improving our growth hormone production. And even BPC-157, we know BPC-157 is healing. And so if there's healing that needs to go on within the airway, could that be something that helps augment the treatment? I don't think there aren't any supplements aside from a peptide that it just dawned on me, but there aren't any supplements that are going to treat obstructive sleep apnea. Are there peptides that are now FDA approved for obstructive sleep apnea? Zepbound, which is GLP-1 GIP, is actually FDA approved for obstructive sleep apnea, but it's not because it treats the obstructive sleep apnea. It treats the weight issue if the weight issue is what's causing the obstructive sleep apnea. But it is a great way to utilize those two peptides, which I do wholeheartedly believe in for all of the longevity benefits. And so that is something that as we're helping the person idealize and optimize their entire lifestyle, I oftentimes will recommend treating the obstructive sleep apnea first and then doing all those things. But if somebody says to me, listen, I'm not going to do it, help me lose weight, help me get into shape, help me idealize everything, and then we'll see if the obstructive sleep apnea goes away, I'll do that too. I just want them to do whatever is going to work best for them. So sometimes losing weight can help. If you're going to reduce the fat in your neck, and we can actually lose fat cells in our tongue.
Weight loss in the tongue. I want to unpack and circle back to the testosterone thing, because when I think testosterone sleep apnea, this is how my brain works with it, right? Because I'm thinking if you have sleep apnea, your oxygen deprivation, your body's going to naturally upregulate hematocrit, hemoglobin, because you're trying to produce more red blood cells because your body wants to live, like it wants to breathe.
Yeah.
On the flip side, testosterone, one of the reasons why guys and girls get more energy when they're on testosterone is because you're producing more erythropoietin, making more red blood cells. But the problem is you don't make more blood, and that can subsequently cause an increase in hematocrit and hemoglobin, right?
Yeah.
So I can see this is very chicken and egg here, right?
Yeah.
Because if you're saying, hey, I have sleep apnea, I'm not getting good sleep, but you also produce testosterone when you get deep sleep,
Yeah.
an adequate amount of basically sleep architecture and also deep sleep and non-REM sleep. Long story short, better sleep, more natural production of testosterone. But I guess I'm unsure how testosterone can cause the sleep apnea,
Yeah. And
unless it is a matter of the testosterone causing the increase in hematocrit and hemoglobin and potentially worsening it because that person already has a sleep apnea. So help me kind of
the
unpack that.
interesting part about it, and as I've done all of my research, nobody really knows. We know that men do have a higher propensity for obstructive sleep apnea, and they do think that because men have a higher testosterone level, also they just have a longer, thicker airway, making them more prone. But it is in the package insert of testosterone cypionate that it increases the risk of obstructive sleep apnea, and I don't think we know why. In the research that I've done, it's just like we know that it does, but from a physiological standpoint, I don't know the answer to that. I probably should dive further into that. It's just that in my previous knowledge and in asking previous sleep specialists that I've worked with, it's like, well, we don't know, but we just know that that's one of the reasons men are more prone, and we also know that I don't know if it does something to thicken. It may have something to do with thickening the airway. But I honestly don't know the question to that. I just know that it is in the package insert, that we do know that as you increase those testosterone levels, that you do have a higher risk of then causing the obstructive sleep apnea. Not a reason not to treat the OSA, though, because if you have OSA and you just falsely, replace testosterone, you're still having all of the other disadvantages of not treating the obstructive sleep apnea long term. So it's like you have to be aware of both, and also to recognize that if you put somebody on testosterone and all of a sudden they start snoring, or they come in and they're like, I'm having a hard time sleeping, and are you snoring, that it could have caused that.
Okay. Makes sense. Makes sense. So you're almost out of here. So close, so close, so close. So I just want to kind of sum because I like the process here. And I think for the listeners here, for kind of like the clues, signs and symptoms is something you may look into. And I think number one, if you're not getting quality sleep, despite doing all the things, right? And so if you're got good sleep hygiene, hormones are good, you're not drinking, your weight's good, and you're still feeling like my sleep is trash, I'm not well rested, I wake up good, I get tired in the day, definitely look into that. If your partner's is noticing that you're gasping or puffing or having issues with staying asleep, definitely another reason to get checked as well. Um, I think those are like the kind of the big two. I think it's just like you said, we talked earlier about just like that I'm functional, but I'm tired, kind of thing as well. And then especially if you look in the mirror and if you do the, open mouth ah test, all you see is tongue. You want to look into that as well. And then just, talk to your practitioner about getting tested. Again, it's way more convenient than it used to be. We're getting tested, which is great. And then if you are diagnosed, just know that the CPAP is, the gold standard, but there are other options out there. to look at that as well. And then don't be afraid of it because the consequences are worse long term if it's not treated. So that's my summary of our discussion here. But did I miss anything? Because I want to make sure we walk away all
Yeah, I really want people to know how easy it is to order home sleep studies. And that was really my big reason for coming up to you after the conference was like, hey, do you order sleep studies? And you said, yeah, I send them, I'll send them to the sleep specialist. And I'm like, they're not going because they don't want to do a sleep study. And so I want people to know you as a provider can set up an account with a company called VirtuWalks. There's many, many other companies out there. That's just one that I know is nationwide. And you can set up an account. You can order home sleep studies because if you have them in front of you, it's like, why do we have supplements at our office? Because we know that if we can just send them home with the supplement, they're going to take it. If we tell them to go buy it, they're going to forget about it. And 3 months later, they're going to be like, oh yeah, I was supposed to do that. If you can order that home sleep study for them or reach out to somebody that does that, learn how to do it. I'm happy to help people figure out how to get that set up. But that was my main purpose in reaching out to you, Dr. Jones, is just saying, hey, do you order these? Because I want people to know, don't be afraid of it. It's not scary. There are many of us that will help walk you through what does it mean? How do you treat it? But at least if you can do that testing in your office and then send to the sleep specialist, A, you just saved that sleep specialist a step. And B, you're actually making sure the patient's going to do it because I don't know how long you had been told like, hey, you should look into, sleep apnea or getting a sleep study. And you're like, nah, I'm good. I'm doing all these other really cool things. So VirtuWalks is a company where you can get set up. And that's really one of the big things that I wanted everybody to understand from this is as providers, don't be afraid. And because there might not even be a sleep specialist in your area, but
yeah, something to look into. So before I let you go, a couple more questions here. Number one, if you could go back and talk to yourself at the beginning of your journey into opening your practice and getting into functional medicine and longevity medicine and all these cool things, what's the one thing you would tell yourself?
I would tell myself never stop learning, which I haven't. Never, ever stop learning because the minute that you feel like you're a specialist at something, you are going to pick up a book, you're going to listen to a podcast, you're going to go to a conference and realize how much you don't know. So never feel like you know everything. That is why I love this field of medicine, functional medicine. All medicine, but functional medicine especially, it's such a tight-knit group of people that just want to help. We want everybody to be their best selves, and we're doing all the things ourselves. And so that's what I love telling patients is I do all these things. I'm doing all the peptides, I'm doing all the things. And so just always know that the minute that you feel like you're smart about something, pick up a book or listen to
You'll
a
get humbled.
podcast and realize
Yeah, you'll get, oh man, you get humbled.
know
Listening
nothing.
sometimes I'm like, oh, no. I was like, oh, hell, I don't know. I've been
Yeah.
messing it up for 3-4 years now. And then you get better.
Yeah.
So, but I think it's good to go into it without the ego because again, you're going to learn something and just, it's all right. That's how you grow and it's how you get better. And the last question is for our listeners, how can we learn more about you and your practice?
Yeah, so it's Ridgeline Medical or Ridgeline Longevity and Aesthetics. I am on Facebook, Christina Finnerty, and on Instagram. And email me. I really don't mind if anybody emails me. So Christina@ridgelinemedical.org. I want to help as many providers and as many people learn about sleep as possible. I would love to be on more podcasts. So please, everybody that's listening, invite me, get me out there. I want that word out there because I just think we're not taught about sleep medicine in school. It's such a it just is at the surface level. And we all talk about in functional medicine how important sleep is, but I feel like we might be missing the boat just a little bit in feeling uncomfortable with knowing what to do when there is actually obstructive sleep apnea present. So find me at all the places.
Okay. And we'll have all that information in the show notes. So we'll have your website, the Instagram, the Facebook, the email address, which I can't say I recommend that, but hey, you know what? I'm sure you have someone
Might
that
blow up.
filters that. Personally, I don't do it. But hey, man, shout out to you. Go off, Queen Christina.
We'll see.
Go off. Give them that email address. And then you're going to be like, I changed my email address, Dr. Jones. Like, yeah, I knew it. I knew it. Alright, so hey, I wanna say thank you for your time. I really appreciate you, coming on and doing this and sharing your knowledge and your passion for sleep and sleep studying and the knowing how important sleep is, not just from because when I gave my presentation, not just from a longevity standpoint, we're talking about preventing, potentially reversing, and getting ahead of chronic disease and how that knowing that sleep apnea is so prevalent, this could be a missing key that can help so many people. So I want to thank you so much for coming on and spending time with us today.
Thank you so much. I am so grateful, and I just really appreciate I learned so much from you and from all of the other providers. So thank you so much for having me on, and I can't wait to do it more.
Yeah, gonna do it. You will, and you will. Just claim it, put it out there in the universe.
Yep, it's out there.
All right, everybody, it is out there. All right, everyone, thank you for listening to another episode of the Dr. Greg Jones Optimization Academy. Again, there will be more information about Christina and her practice and where to learn more about her in the show notes. And until next time, let's stay optimized.